3, 2, 1. We all are live now. We can start the session.
Namaskar and good evening, everyone. I welcome you all for today's webinar on lung cancer update, newer treatment opportunities available at doorstep. With immense pleasure, I would like to invite Dr. Naresh Somani, who is Director Oncology and HOD Medical Oncology at HCG Cancer Center, Somani Hospital, Jaipur, to set the ball rolling and to take the proceeding further. Over to you, sir.
Thanks, team organizing. And before I start, let me thank in the very beginning to the sponsors to arrange the webinars continuously and supporting so that we can understand, we can make the impressions again and again what's new going on. Now, selecting for the today's topic, 2-3 things were in my mind. I discussed with my good friend, Dr. Lalit Sarma, that we always talk about the newer things. We talk about that what's new or what's the standard. But sometimes, somewhere we forget that what's the new things, especially opportunities and availability of the clinical trials in the various phases. Even I say that biosimilars are available in our surrounding, in our own setups across the various centers, that always we should try to discuss. So I requested him, and as usual, you all know that Dr. Lalit always takes this challenge to collect the data, to give the insights about that what's new. So he will be giving us about the what's new in our surrounding. And you all will agree with me that now we are little bit having more and more patients who come in the stage 3 and sometimes in stage 2 or 3 inoperable setup. And now new exciting treatment, both for the driver mutation positive as well as for the other patients. Adjuvant treatment, new adjuvant treatment in the resectable setting, chemotherapy, immunotherapy, target molecule, they all are coming around the resectability in the lung cancer. And who can be a better person than Professor Malhotra sir to tell us about this? Now, sometime I wonder that we talk a lot, we give the stress and we try to give the immuno-oncology drugs, which are being widely prescribed in NSCLC, whether it's in the first line or in the subsequent line. But the drug immunotherapy, which is being approved in the small cell lung cancer extensive stage in the first line, is most of the time being missed by all of us. So whether it is that we are not believing the data, whether it is a cost factor, logistics, or whether it's something different, which is making the less utility of the immuno-oncology drugs in the small cell lung cancer. So that also will be discussed by my good friend and young budding medical oncologist from the HCG Cancer Center, Dr. Ankit Nehra, and Dr. Sajjan Rajpurohit, whom I believe that he is not the medical oncologist from the Jaipur. He is our own medical oncologist with his roots from the Jodhpur, where Dr. G.S. Bhati is there. And we all know that if the Bhati sir is there in the Jodhpur, all medical oncologists, they have to work under him. They have to go according to his acumen. So Dr. Sajjan Rajpurohit will be delivering on the panel discussion. And in our panelists, our medical oncologists, radiation oncology from the different centers will be discussing that what they are thinking about the various aspects in the management of the NSCLC. With this background, let me invite and I request all of you on my behalf to welcome our chairperson for today's talk, Dr. G.S. Bhati sir, senior medical oncologist from Jodhpur, good friend of most of us people. He is like mentor for most of us people. And like Dr. Bhati is taking care of the half of the Rajasthan, Professor Malhotra sir is taking the remaining part of the Rajasthan. So with that, I invite Dr. G.S. Bhati to start the today's proceedings. Thank you and welcome once again to all of you.
Thank you, Dr. Somani, for a kind introduction, and for me and Dr. Malhotra sir for so kind words. And we will be always happy to have a good relations, and this is the basic thing for our relationship as well as the patient-doctor relationship that helps a lot. Now we will not waste time, and I will invite our lovely medical oncologist, Dr. Lalit. He is the assistant professor in medical oncology and hematology at Mahatma Gandhi Medical College, Jaipur. and he will speak on the clinical trial opportunities in lung cancer. Dr. Lalit, please.
So thank you so much, sir, for your kind words. And we all respect you, Professor Malhotra, sir, and our senior colleagues. And we always feel happy that you are there to guide us in all clinical, non-clinical, paraclinical aspects. Thankful to Dr. Somani for taking us on a common platform repeatedly on various aspects. So the today's topic given to me is clinical trials in India. And before I start, in fact, let us think that what makes the celebrities to move out of India for various cancer-directed treatment. Are there different drugs? Are they much better, or the hospitals are much better, or the care is much better there? And why do they have improved survival? This is what common man thinks. So this is again very important that most of these fellows, they are undergoing in some clinical trials, and the clinical trials, the care is better, and I'll try to convey that what are the advantages. So the topic given to me is clinical trials in India. So we all know that clinical trials are essential in the medicine part, whether it is vaccine, drugs, all these drugs, whatever we are using has gone through. India's population is rapidly rising. So we will have more and more of elderly population. We will have more and more of cancer cases. So cancer incidence is also rapidly rising. And all the modern Western drugs, they are expensive. So not only we need to be updated with our own drugs which are coming new, but again, there is a strong need of clinical trials which are beneficial and which are practical in our own settings. Most trials are being done in Western world, and the contribution to India, I'll tell you, trials are the best way to help our eligible patients. This is the decadal increase in the total population life expectancy. So we can see that around in 1901, the total population was this, and now we have grown huge. And if we see the life expectancy also is going high, and if you see the senior citizens of 60 plus population, that is also going high. It means that more and more life expectancy is improving, more and more senior citizens will be there, and we all know that cancer is ultimately a disease of elderly population more than the younger population. So we are going to face more and more cancer cases. Why there is need for clinical trials in India? The clinical trial need in India because of the clinical trials are the way forward to evaluate a new medicine, especially by means of clinical trials. It is a way to search for understanding the safer and better treatment options for our patients. And in India, in fact, if you see, the completion time is less, the number of patients is much higher, and the cost to the sponsors is also very less as compared to Western world. So there is a scope of having clinical trials in India, in Jaipur, in Rajasthan, and pan-India. If you see the standards of clinical trial conducted in India, it has already risen to the international requirements, and India is at par with any other global trial hub centers. So there is a good scope. There are good number of patients. We all are experienced. So we should have more and more of clinical trials in India also. If you see about the global clinical trial activity in 2020, India contributed to 8.3% of total clinical trials, which was 11% in 2019. This may be because of the COVID effect, but currently we are contributing to almost 10% of the global trial activity. Not only the industry sponsored trials, but we can see that non-industry sponsored trials outnumber the industry sponsored trial, and we can see the industry sponsored trial 35% versus 41% were non-industry sponsored trial in India. So this is industry sponsored, the black one is non-industry sponsored. So we can see that this is a myth that probably industry sponsored trials are higher, but we can see that non-industry sponsored trials, which are sort of sponsored by various scientific agencies, they are getting higher in 2020, and this is also very important for us. Then comes the industry sponsored trial. So we can see that infectious diseases are very, very high in India and low middle income countries. So we can see good number of infectious disease trials in India. And we can see the oncology trials, which is almost 37.5% of total. And in 1 year in 2020, it was 9%. So India, we are contributing around 9 to 13% of oncology trials globally. And we can see metabolic disorder, diabetes, hypertension, all these are also high numbers. So we are having good number of clinical trials in India, industry sponsored. Then comes the, if you see the top therapy areas of non-industry sponsored clinical trials, then comes the CNS part, infectious part, GIT and oncology contributes to almost 7 to 8% of these non-industry sponsored clinical trials. How about phase 2 trials in India? We can see that phase 2 trials in India, by the 1 year average was 32%, while in the 10 years and 5 year average is 23 and 26% respectively. We can see phase 3 trials, that 10 year average is close to 38 as compared to others. And this is phase 1. Phase 1, of course, is very less and it is mainly the institute based. And I'm happy that Dr. Somani was also part of one phase 1 trial in my previous institute. The non-industry sponsored phase 2 trials, if we see, the 10-year average is 57% of total trial, while 5-year average is 59 and the 1 year is 50%. So we can see that even non-industry sponsored trials, that is also good number being seen. Why India is emerging as global hub for trials and what are the opportunities for us? We can see the India clinical trial market is expected to reach this much figure in next 5 years with a compounded annual growth of 8.7%. The whole world is looking at India as a global hub, not only for treatment but for clinical trials also. And this is due to because of the India advantage. What are the India advantage? Availability of large number of patients are there with us, highly motivated and skilled medical oncologists and medical manpower and paramedical staff and hospitals are there. Strong information and technology system is available with many of the centers in India, and increasing number of pharmaceutical companies are there in India, and various CROs, they are already approaching to Indian doctors for various international trials. So this is high time that we all try to understand and we all try to contribute to that. This is about the benefit and risk. We all know about the benefit and risk of clinical trials. These are the benefits of conducting trial, that naive patient with heterogeneous population is available, and we have high incidences of cancer, diabetes, and other diseases. The cost of trial is less as compared to the Western world trial. So we are having a good opportunity. English is also very well with India. What are the barriers? Why we are not able to recruit a good number of patients in clinical trials? Patients may not be aware of the clinical trials, and even doctors may not be available of clinical trials. Even we have seen that in the same institutes, the other colleagues are not available, not aware of the clinical trial. So there could be bad media. Press also many times confuses the patient's population, and they of course many times give negative news. Fear, distrust, and suspicious of research. Everyone feels that in the trial they will not be treating me well and they may treat like a guinea pig. Practical or personal obstruction may be there. Insurance or cost problems may be there, or sometimes may be unwilling because of the physician's wish. Many times our own colleagues or many times the referring physicians may not be fully comfortable. These are common prevalent diseases against which trials are available, and we can see oncology is also having good number. What are the advantage of having trials in India? We can see this is paper from Dr. Kumar Prabhash group in Tata Hospital. They have published low-cost oral metronomic chemotherapy versus IV cisplatin in patients with recurrent head and neck carcinoma. And we can see the results are much better with oral metronomic chemotherapy. Dr. Banavli has also published a lot of articles on oral metronomic chemotherapy. Western world will never have such a trial on oral metronomic chemotherapy, but we need it. Our patients need it. Our brothers and sisters need such trial, especially in metastatic setting, that if we can get something which is cost effective, which is good for our patient, and which is sort of having good quality of life. So we need to see answers of such phase 3 trials in our own country, in our own setup. We need to again talk to the media also, because media also publishes many times such negative news. So we need to be very careful, and we need to sort of have meetings with media also, so that they can understand the meaning and importance of clinical trials also. This I have borrowed from Dr. Purvesh Parikh sir, and thankful to him, that we always know that 5% of population in India, they can go for any treatment anywhere on the earth. So they are highly affording class. This is middle class. So middle class is constituting almost 1/3 of the population, where they always look for some schemes or some government schemes, some insurance, something like that for their treatment. And if you see the bottom, this is almost 2/3 of Indian population, where there is very difficult situation, in fact, and they need good health care, they need good treatment with a dignified way. So I think for such groups, such large group patients, the clinical trials remains very good option if we offer them properly and if we evaluate them properly. With the clinical
My
trial advantage,
apologies,
we
sir.
can see lung
My
cancer.
apologies, sir. You're
Yes.
just left with 1 minute to conclude your presentation.
Okay, I'll do. So we can see the Ibrutinib will be just at the Mahatma Gandhi Hospital. So this is one trial available on breast cancer, HR positive, HER2 negative breast cancer, who have failed 1 or 2 prior lines of chemotherapy. And this is Dato-TDX drug, which is a very good drug tried in various lung cancer studies. This is another trial available to us, which is on phase 3 trial. And this is non-small cell lung carcinoma after CT plus RT. Those who do not progress, durvalumab plus this IP will be available, and this will be given for 1 year. We have accrual completed for these 3 trials, and one more trial is with us, which is on hepatocellular carcinoma. So to conclude, we can see that these are need for better drugs, best patient care can be there, and newer molecules and targeted therapies can be made available. India is best hub, and we need to have our own country-specific clinical trials. And of course, collaboration between us is important. Cross-reference for enrollment is also equally important. So with this, I thank you all for patient hearing. Thank you so much.
Thank you, Dr. Lalit, for a nice presentation. And the atmosphere for the clinical trial is the best in the India, and India is having one Europe. So we can do the best trials, and this has been started from the institutions like TMH and the other topmost institutions of the cancer in the country. And this has been increased, or growth has been increased, or done by ICON group. The concept for establishing ICON was just to do the clinical trials, the more important job. And we had a meeting in somewhere 2002, Purvesh Parikh sir and the Hemant Malhotra sir first meeting in the Jaipur. So still I remember, and now the individual medical oncologists are also participating in a nice way. And my view is we should give the younger people take home message how to interpret the clinical trials and what are the relevant trials. So time to time we should give them the message. Thank you very much. And now I will invite Dr. Hemant Malhotra sir for the next talk, and he will speak on the newer paradigm in the treatment of resected EGFR metastatic lung cancer in different scenarios. Dr. Malhotra sir.
Thank you, Dr. Bhati, my very dear friend from Jodhpur, and Dr. Naresh, my very dear friend from Jaipur. And I think let us all join in congratulating Dr. Lalit Mohan Sharma for a very nice talk on a very difficult topic. And may I also suggest, may I request Dr. Somani, like we have a nationwide group for clinical trials, maybe we can have a Jaipur group or a Rajasthan group, again a WhatsApp group, in which we can share our trial titles and our inclusion and exclusion criteria, and we can share patients also, which will benefit the patients and help in our recruitment also. So maybe Dr. Somani can take the lead and make a Rajasthan clinical trials WhatsApp group.
Yes, sir. So I just shared on the chat group that there is a group across the country also. So we can make the group of the like-minded people, those who will be interested, to share their information and availability of the trial. and which can really help the patient a lot, or the newer molecules or whatever it is. And then we will be seeing that probably there will be more recruitment, patient will be benefited, and probably for the same molecule, they unnecessarily need not to travel to the premier institutes like at the Delhi or Mumbai or somewhere, where the life or staying for some days to get the trial molecule and going again and again itself is a big challenge. So I accept
Absolutely.
this role being proposed by Professor Malhotra. I will be doing it.
Thank you very much, Naresh. So if I may be permitted to share my screen now. And as already pointed out by our honorable chairman, my brief today is to talk about adjuvant treatment in resected EGFR mutated lung cancer. So please note that I will not talk about adjuvant chemotherapy. I will not talk about first line treatment. I'll only talk about adjuvant treatment. So in the West, about 20%, 1 in 3 patients or 30% of patients are, present in resectable stage. But because of various reasons, which I won't go through just now, in our country, this number is much less, and maybe 10 or at the most 20%, 1/5 of the patients we can call as operable or resectable. And we are aware that lung cancer is the leading cause of death, not only in the world, but in our country also. And non-small cell represents about 85% cases of all lung cancers. And in our country, as already said, the operable number of patients coming to us is between 10 to 20%, means 1 out of 5 patients. If you properly stage the disease and the patient has stage 1A or 1B disease, this is known as localized or early stage disease. And then locally advanced disease is stage 3 and stage 2 and stage 3A. And both these are also amenable to surgery. So outcomes in lung cancer, we know even if you have an early stage disease, even if the patient comes in stage 1B or localized lung cancer, the 5-year recurrence rate is 45%, means about 50% of the patients will recur. And as you go up the stages, stage 2, almost 2/3 will recur. And if you have stage 3, then 3/4 of the patients will recur. So obviously some form of adjuvant treatment, some form of treatment to take care of the micrometastasis present at the time of surgery has to be incorporated. Adjuvant chemotherapy is well established in patients who have stage 1 disease, stage 2 disease, and stage 3 disease. But we do know that chemotherapy is less effective as compared to targeted therapy in non-small cell lung cancer patients, which have a target gene driving the tumor. And one of the very important target genes is the epidermal growth factor receptor mutation. And in our country and in other nation countries, as many as 1 out of 3 patients will harbor the EGFR mutation. And we have a huge volume of evidence to tell us that in patients who have the EGFR mutation, our targeted treatment, our tyrosine kinase inhibitors, are significantly better than chemotherapy. Now, can this be translated to a treatment in the adjuvant setting? So there has been a whole bunch of phase 3 adjuvant trials of EGFR inhibitors in early EGFR positive non-small cell lung cancers. And if I were to just summarize the trial, and only the first generation EGFR inhibitors have been used. In the SELECT trial, we had erlotinib. In the RADIANT trial, again erlotinib. In the UN trial, erlotinib. And the 2 trials over CTONG, we had gefitinib. BR19, we had gefitinib. And some of them were positive trials, small benefit, but most of them were negative trials. And in fact, erlotinib was approved in the maintenance setting in patients of EGFR mutated non-small cell lung cancer. Now we have a new kid on the block. We have a new phase 3 study, which is known as the ADURA study, in which patients were randomized to receive ADURA, were randomized to receive osimertinib versus placebo in the adjuvant setting. So I'll discuss this study in a lot more details. This also merited NEJM paper, which was published on October 29th on 2020. And this is the study. I'll talk to you about the ADURA study. It was a phase 3 double-blind randomized study in patients of non-small cell lung cancer, either stage 1B, 2, or 3A, with or without adjuvant chemotherapy. They were stratified to receive osimertinib 80 milligrams once a day in one arm or placebo in the other arm. And the planned duration of treatment was 3 years. The treatment was continued until disease recurrence, treatment completion, or any other discontinuation criteria. The follow-up, initial follow-up was every 12 to 24 weeks, and then every 24 weeks to up to 5 years, and then yearly. Primary endpoints were disease-free survival by investigator, and secondary endpoints were disease-free survival in the overall population and overall survival, safety, and health-related quality of life. So this was one of those studies in which the disease monitoring committee found so much difference in one of the arms of the study, because this was a blinded study. In one of the arms of the study, there was so much difference that the study had to be unblinded early, and the study had to be terminated because it would have been unethical to not give the placebo arm the opportunity to take the investigational product. The investigational product arm was so much significantly better, and we'll see the results in the subsequent slides. So just to revise the inclusion criteria for you: patients more than 18 years of age, non-squamous non-small cell lung cancer, all of them operated either stage 2B or a 1B or 2 or 3A, central confirmation of the EGFR mutation. If the patient was a candidate for adjuvant chemotherapy, all patients had to finish at least 4 cycles of platinum doublet chemotherapy. It was allowed but not mandatory. The patient could be accrued in that study even if the patient had not received adjuvant chemotherapy. MRI of the brain was essential prior to the surgery, and the patients had to have a good performance status. You can see 300 plus patients in both the arms, the osimertinib arm and the placebo arm. And with regards to the various baseline characteristics, the 2 arms were very well matched. And here are the results for you. The primary population, which consisted of patients of stage 2 and 3A, there was a massive difference in the progression-free survival. And you can see the hazard ratios over here, a hazard ratio of 0.17 and a p-value of 0.0001. So very rarely in a clinical trial you see the Kaplan-Meier curves so divergent. And the same was true in the overall population also, which included, in addition to stage 2 and 3A, stage 1B. So 83% reduction in risk of recurrence or death with osimertinib in the stage 2 and 3A population, and 80% reduction in the overall population. And this difference was very clearly highlighted across the stages, whether the patient has stage 1B, slightly less impressive hazard ratio, but a very impressive hazard ratio for stage 2 patients and stage 3A patients, 0.17 and 0.12. I rarely remember a study in which I have seen a hazard ratio of 0.12 between the investigational arm and the control arm. And this is the subgroup analysis for you across subgroups, whether male or female, age less than 65, more than 65, smoker, non-smoker, Asian, non-Asian, stage, which of the two EGFR mutations, whether adjuvant chemotherapy was received or not. Across the subgroups, osimertinib was better than placebo. And I'd like to point out to you these three particular subgroups, smokers, patients in 3A, and patients who had exon 19 deletion, they had a hazard ratio of less than 0.2. So like some special activity in these three subgroups as per the subgroup analysis. It is too early to estimate the overall survival in these patients, and that data we very eagerly await. All of us who treat lung cancer know that the site of recurrence of lung cancer is very important, and local recurrence versus distant recurrence has a very big impact on the patient's subsequent treatment and the subsequent patient survival. And we are really frightened and afraid that the disease should not and may not come back in the central nervous system. It was observed in this ADURA study that the majority of recurrences were local. Almost 1/3 of the patients had local recurrences, as compared to in the placebo group, it was distant recurrences. And it was also seen that the common site of recurrence was the CNS, only 1 in the ADURA arm and 10 in the placebo arm. The CNS disease-free survival events were again much lower, statistically significantly lower in the osimertinib arm as compared to the placebo arm. And the CNS disease-free overall survival Kaplan-Meier curve, again, the hazard ratio between osimertinib arm, the green curves, and the placebo arm, the yellow curves, was 0.18, and a very healthy p-value. Now, what about safety? Whenever you're using an intervention in the adjuvant setting, you are particularly concerned about the safety. So even though grade 3 or more adverse events were slightly more in the osimertinib arm, but not hugely more, and AEs related to the investigational product, again, a little more than in the placebo arm, but very few grade 3 and more adverse events in the osimertinib arm, and no grade 5 adverse events. So here is the summary of the adverse events seen: diarrhea, paronychia, dry skin, pruritus, cough. These were the common adverse events which were seen in this study. There was another publication and presentation in which the group of patients who received adjuvant chemotherapy versus those who did not, this was also studied. So about 26% received adjuvant chemotherapy in 1B, 71% in stage 2, and 80% in stage 3A. And again, whether the patient received adjuvant chemotherapy or did not receive adjuvant chemotherapy, there was a significant difference in the progression-free survival, in the disease-free survival. This is in the overall population, and this is without chemotherapy. And if you look at the hazard plots over here, the green dots represent patients who received adjuvant chemotherapy. The purple dots represent patients who did not receive adjuvant chemotherapy. So across subgroups, there was benefit in the osimertinib arm. This benefit was a little less in patients with stage 1B who received adjuvant chemotherapy, but significant benefit who did not receive adjuvant chemotherapy. Just conveying to us that some form of adjuvant treatment, either chemotherapy and or osimertinib, even in early stage disease, is beneficial for the patient. And then, of course, in stage 2, a significant difference with or without chemotherapy. And in stage 3, again, even a bigger difference between groups which received the EGFR inhibitor versus the placebo. Patient-related quality of outcomes were also assessed in a separate publication and a separate presentation. The SF36 health survey was used. This compared physical component parts and mental component parts and 8 health domains, which included all these 8 parameters which directly impact on quality of life of the patient. A very large number of patients in both the groups, osimertinib as well as placebo, were compliant. More than 85% were compliant and data was available. And you can see here that whether you look at the PCS or the MCS, there was no deterioration in quality of life when the patients received adjuvant osimertinib. So this again, as I said earlier, is an important consideration when you're talking about adjuvant treatment. So if I were to summarize, adjuvant osimertinib is the first targeted agent in a global trial to show a statistically significant and clinically meaningful improvement in DFS in patients with stage 1B, 2, 3A EGFR mutated operated non-small cell lung cancer. There is a 80% reduction in risk of disease recurrence or death with osimertinib. We've already talked about the hazard ratio of 0.2 and a very significant p-value. So DFS rates at 2 years was 90% for the osimertinib arm and 52% for the placebo arm. Adjuvant osimertinib demonstrated a clinically meaningful improvement in CNS disease-free survival as compared to placebo, and the safety profile of the drug was in sync with the usual safety profile of the drug, and there were no major toxicities and there was no deterioration in quality of life. So a clinically meaningful DFS benefit was observed in patients either if they received adjuvant chemo or if they did not receive chemotherapy, adjuvant chemotherapy, both the groups showed a benefit. And also very importantly, the overall health related quality of life was maintained. So in summary, adjuvant osimertinib will provide a highly effective practice-changing treatment for patients of stage 1B, 2, 2A EGFR mutated non-small cell lung cancer after complete tumor resection and after adjuvant chemotherapy if indicated. As per the data of the ADJURANT trial, the FDA has approved osimertinib in this indication in December 2020, and the European Union has also approved the drug in the adjuvant setting in May of 2021. And you may also like to know that the Drug Controller General of India has also approved osimertinib for use in the adjuvant setting in the clinical situation which I've just described. NCCN guidelines, the latest version, there are 2 drugs which are mentioned in adjuvant systemic therapy. One is osimertinib and the other is atezolizumab for the PD-L1 positive non-small cell lung cancer. And we haven't talked about this today. So with this, I'd like to close my presentation and my most sincere thanks to Dr. Somani for this opportunity. Thank you very much.
I have the 2 questions for you, sir, if being permitted by chairperson.
Yes.
I have said in
Yes,
the
Dr.
chat
Somani,
box.
go ahead.
I have said in the chat box also that if the EGFR positive and patient cannot afford osimertinib, likely for most of the patients, can we extrapolate it with the gefitinib? And if not, why? And what about the same situation and the ALK positivity? Would you like to give them the TKI in the ALK positive also?
So I think this is a very, very important and very, very relevant question. The osimertinib, pardon me, is an extremely expensive molecule and probably out of reach of most patients. So this question again becomes important. As far as I'm concerned, in my mind, after I finish adjuvant chemotherapy in this group of patients in which is indicated, I put all of them on erlotinib, and I've been doing it for 20 years. Somehow have never got around to publishing the results, but I do believe that it should be done. There is some data which I already showed you, some 4 or 5 trials are there, plus minus data. Of course, you have to keep the toxicity in mind, but with this Adura data, that reinforces my belief that adjuvant EGFR inhibitor, whatever the patient can afford, can and should be given. Your second question regarding ALK positive patients in the same setting, again, which of the ALK inhibitors one should use, whether the ALK equivalent inhibitor to osimertinib, meaning the third generation one, prolactinib, whether that is the one which one should use, or one should use one of the other agents. Again, there is no hard data to that fact, but trials have started. The problem is that the ALK positive numbers are much less than EGFR positive numbers. So they will probably have smaller number of patients and will take a longer period to accrue the number of patients.
Doctor
Thank you,
sir,
sir.
one question from my side. Earlier, when there was no, these molecules were not available, dapitinib, erlotinib, osimertinib, nothing was available. And we used to give the chemotherapy, and patients used to ask us, if I don't go for chemotherapy, how long I will live? And if I take the chemotherapy, then how long I'll live? What will be my quality of life? So you also told the quality of life with osimertinib, or you have also told about the role of the erlotinib. If we compare all these things, then in terms of overall survival, what is the difference? Only we are giving chemotherapy versus erlotinib or dapitinib, or and then osimertinib. How will you rate overall survival? What will be the roughly overall survival?
So I think the one important thing which needs to be highlighted here, that there are very few operable lung cancer cases in our country. So some institutes say that it is less than 5%, and some, big cities where the awareness is more and the diagnosis is more vigorous, then it could be up to 20%. So the number of patients eligible for an intervention like this is less. We have data since the past 15 or 20 years that adjuvant chemotherapy, you will remember the Anita trial and several other studies, adjuvant chemotherapy imparts a 4 to 8% benefit to these patients. So meaning that if you give adjuvant chemotherapy to 100 patients, 8 out of those 100 will benefit. And we don't have ways and means to decide and decipher which patient will benefit and which patient will not benefit. So like the benefit appears to be small to us, but if you have 8 patients more surviving, 8 patients more cured out of 100, that becomes a significant number. So if you have to be completely honest with the patient, you have to talk to the patient about these numbers and let the patient decide. And nobody will deny that adjuvant chemotherapy after a big chest surgery is sometimes difficult to tolerate.